We're so glad to see everyone. Welcome to the CMDA meeting and to Journal Club, and welcome to
Try
2025.
to ignore this.
Hi, Dr. Stoffer. Welcome to everyone who's logging on. It is 12 noon, and I'm Sing Pallet, the president of CMDA, joined by my colleagues on the board, especially Drs. Chris Horton and Leslie Eber, who are helping to moderate today's meeting. We've decided to combine our monthly meeting and journal club today because of the holidays and the new year. And we're very excited to see all of our speakers who are going to be presenting today. Our first presentation will be on the PASRR, and it's going to be presented by Margaret Anderson, the PASRR administrator for the state of Colorado, and Chellie Voss. Dr. Voss is the PASRR program manager. She's with the State Mental Health Authority and Behavioral Health Administration for the state of Colorado. And I'm going to go ahead and stop sharing. And I know that Dr. Voss has some slides to share with us. And hello, Margaret. Thank you for joining us as well.
Are you guys seeing the slides?
We are seeing the slides. Thank you.
Perfect. Okay. Well, welcome everybody. Good morning. It's a pleasure to be here with you and get to share PASRR with this group. My name is Chellie Voss. I use she, her pronouns, and I am the PASRR program manager at Behavioral Health Administration. My background is in clinical psychology. I've worked with the SMI population for about 25 years. I've worked in inpatient psychiatric units, community mental health centers, excuse me, nursing facilities, managed Medicaid agencies, and my passions are crisis and emergency services as well as complex care coordination. So PASRR kind of dovetails into that PASRR or into that complex care coordination. I've been with PASRR for about 15 years and started as a level 2 evaluator, and I've been in my current role for about 5 years. I'm going to pass it over to Margaret to introduce herself, and then we'll get started.
Hi, I'm Margaret Anderson, and I'm the PASRR administrator, and I work at HCPF. So I oversee the administration of the PASRR program, and I'm the state Medicaid authority for PASRR. So that is my side of it. My background is with CDPHE. I worked closely with Chad and Joe as a surveyor, so I'm going to cover that area today as we talk. So thanks for having us. And I know that I'm going to turn my camera off while we do the presentation so I can read my notes, but I will come back on for questions.
All right. I'm actually getting like an internet error, so I'm going to turn my camera off as well and hope that will help. I don't know that it's impacting you guys at all. Okay.
Seems okay so far.
Okay, well then I'll leave it on. So I just wanted to start with some level setting, and actually I'll put this out there. If you guys have questions, we're going to hold questions until the end, but you can certainly put them in the chat if you're afraid you're not going to remember them at the end. We're planning on about a 15-minute presentation today, and we definitely have time for questions and answers at the end. So again, if you could hold questions and put them in the chat, we'll get to them. So PASRR stands for Pre-Admission Screening and Resident Review. It's a federally mandated program that was created back in the late 80s when we were deinstitutionalizing and closing a lot of mental health institutions. It's a person-centered approach and assesses needs for care and care coordination for individuals living in Medicaid certified nursing facilities. PASRR ensures that any known or suspected behavioral health, intellectual disability, developmental disability, or related condition be identified so that the individual can receive long-term services and supports in the most integrated setting, and that they're able to get those services coordinated into their care plan at the nursing facility to have a successful stay. PASRR is administered by HCPF, where Margaret is housed, and the clinical oversight of the program is through BHA, the State Mental Health Authority. So here in Colorado, there are interagency agreements between HCPF and CDHS or BHA, and HCPF also has an interagency agreement with CDPHE. And those interagency agreements outline our different roles and responsibilities for PASRR. We all work really closely together, as Margaret mentioned, in monitoring compliance of nursing facilities and holding them accountable for PASRR compliance to the federal. Our PASRR program here in Colorado provides training. We provide ad hoc compliance consultations to CDPHE nursing facility surveyors. And to give you guys an overview, for those who may not be as familiar with PASRR, PASRR is a screening. It starts with a screening. So every single individual prior to admitting to a nursing facility that accepts Medicaid dollars is going to receive a very basic screening for mental health, IDD, and developmental disabilities. During that process, if there is the potential that this person has a mental health condition or has an intellectual or developmental disability, then they would get screened positive and they would trigger a level 2 evaluation. So you have that basic screening, someone screens positive, it bumps and triggers a level 2. That level 2 evaluation is a much more in-depth, it's a full biopsychosocial assessment. We do require a copy of current meds, copy of a review of systems or H&P. So it's a full assessment to get to know the individual, identify their treatment needs, make recommendations, and identify clinical interventions. So that level 2 is your clinical document in the PASRR process. Once that level 2 is completed, then the NOD, which is the Notice of Determination, is issued by the state. So your level 2 is your clinical document. Your NOD is your legal document. That NOD is what tells the nursing facility, hey, these are the services that have been identified that you need to make sure that are coordinated for your resident. There are 2 different time frames for PASRR. Certainly it's pre-admission. Before this individual ever enters your facility, we want to screen them. If they're at your facility and something changes, and I'll just give you a quick example. We recently had somebody who went to Denver Health, needed inpatient psychiatric stabilization. So they will need a new level 2 before they go back to their nursing facility, because certainly their level of care needs changed. And we want to make sure that the level 2 is updated and clinically accurate. So here in Colorado, our rules have not been updated for a really long time. And I'm kind of ashamed to say that. We're working on updating them, but currently the rules reflect DSM-3. So we're really out of date. But this, I gave you guys a copy of the current Colorado rule, and then wanted to let you know that we are in the process of updating our rules. And I'm looking forward to getting kind of a less diagnostically driven determination process and really more clinically subjective when we consider the severity of symptoms, the duration of the episodes, the functional impact to the individual based on their condition. So that would put us more in line with the anticipated federal changes that are coming soon. But right now, here in Colorado, it's really diagnostically driven, and it's just those diagnoses that are listed on the copy of the rule. When we update our rules, we're really looking at right now PTSD or a very severe anxiety disorder or panic disorder isn't included in our current rule as being determined for serious mental illness. Personality disorders aren't listed in there. So I really want to go to a place where we're taking an individual, looking at everything and then how it impacts their functioning and not just being tied to diagnoses. And I think one of the questions that Dr. Pallett mentioned that the group had was related to major depressive disorder. And so as we move into these updated rules, what I'm thinking is that if an individual has a single episode of depression or mild depression in the future, that wouldn't necessarily be an automatic PASRR condition. We're looking at more moderate to severe, recurrent, those sort of specifiers related to major depressive disorder that would then put us into that category of serious mental illness. Dr. Pallett also mentioned wanting to know if we are using DSM criteria, and we can get more into the question if I'm not answering this sufficiently, but currently we're using DSM-5 TR codes in all of our PASRR evaluations. So just some interesting facts for you guys. We process over 30,000 level 1 screens per year. Historically, about 10% of those level 1 screens trigger that more in-depth biopsychosocial evaluation, that level 2. Every single level 2 evaluation is read by the state, either Margaret or myself, to ensure quality and appropriate clinical determinations and interventions. Something that's unique to Colorado, there's only a handful of states around the country who do this, but Colorado, every single mental health level 2 evaluation is also read and co-signed by a psychiatrist. And then our main stakeholder groups are the hospitals across the state, the nursing facilities, as I'm sure you guys are aware, and then our Medicaid case management agencies. And that case management redesign, excuse me, just took our case management agencies and our community center boards and combined them. So that's that stakeholder group. So I mentioned we do have some potential upcoming changes to PASRR. Back in 2020, February of 2020, the notice of the federal notice of proposed rulemaking was published by CMS, and it was out for comment. A lot of work went into providing comments from states, from organizations like the National Association of PASRR Professionals, and then it got shelved because of the public health emergency. So we keep hearing rumors that they're going to dust that off this year. We hope that's the case because the federal rules haven't been updated in a really long time either. So we're anticipating those rules coming out off the shelf later this year. And that's also informing Colorado wanting to update our state rules to be in compliance with what we anticipate is going to be on the horizon. And then, like I said, here in Colorado, we're getting ready to update our rules. Talked about the pending updates for the definition of serious mental illness. I don't anticipate there will be any changes to the definition for IDD or related conditions. We do anticipate some updates to time frame regarding PASRR reporting and turnaround times for PASRR level 2s. And lastly, in addition to these potential rule changes, I know Margaret's really working hard right now to clean up our website and make sure that our training resource section is user-friendly and easy to identify where trainings are that might be helpful to our stakeholders. So this is probably where you guys have heard most about PASRR, is with our pain points. So I wanted to go through a couple of frequently asked questions, situations that may come up. So a lot of questions that we get are if our nursing facility admits someone with an incorrect PASRR, whether, let's just say, the hospital discharge planner didn't put a diagnosis in that they should have, and they wanted that easy admit and got their provisional admission and they were good. Or incorrect medications are listed, diagnostic clarification, they're admitted before the entire PASRR process is completed. In those situations, the solution is to submit a new level 1. So that wouldn't necessarily be the folks on this call, that would be your social services directors, but that is the process for correcting an incorrect PASRR at that level 1 stage. This situation came up a couple of years ago. What if our staff disagree with the level 2 diagnosis or an identified clinical intervention or the determination? So with the level 2 diagnosis, if you as a provider or your IDT staff disagree, if you have additional clinical information that was not provided, we are happy to do a new level 2. If that would change the outcome, if it would be more accurate and in line with what you see as the provider of record, then we can do that. The providers themselves cannot challenge or appeal a determination. That comes from the individual resident and or their family, and it has to be done within 30 days of receiving that notice of determination. So with that level 2 diagnosis, if you don't have new information, but you have known this person, in the situation I had, the individual had a known bipolar disorder, bipolar 2, and the provider had been seeing them for years. We said, we're not going to do a new level 2 because we had all the information that you gave us and you don't have anything new. But you know what? our level 2 is co-signed by a psychiatrist. And if you continue to disagree with that, that's okay. Just document it in your records, because it's going to be different than what's on the PASRR. And when survey comes in, you want to have that documentation to show that we talked about it. PASRR office at Colorado has talked to the nursing facility. We've had a discussion about it, and this is the solution we came up with. If you disagree with an identified clinical intervention and you feel like it's no longer appropriate, or you feel like it was never appropriate, you can simply document that. You don't need to request a new PASRR for that. The level 2 evaluators, when they're making their recommendations, they're giving ideas of anything they think would be helpful. So if the individual refuses to participate, that is okay. Just document that. If you as a provider think there's no way that this person is going to participate, then document that it was offered and that it would have been coordinated, but they refused. That's okay. If you feel like there's no way that you guys can coordinate the service, and an instance I'm thinking of is a level 2 identified a neurocognitive disorder, and the local mental health center said, we're not going to be able to see this person because we can't bill it because primary neurocognitive disorder. In that instance, we just said, you know what, that's okay, just document. We don't want providers to provide services that they can't bill for, that sort of scenario. And really that never should have gotten through as a requirement because neurocognitive disorder was primary. And we'll talk about the exceptions to PASRR as well. Why can't our nursing facility staff see the PASRR documentation in the electronic portal? That typically is a visibility issue with Telligen. So at the end of this, or maybe Margaret, if you're able to, can put the Telligen help desk number into the chat. And that way you guys can pass it along to your social services staff. And if they don't know how to change visibility in the system, they can call the help desk. Next question is, what does the nursing facility do if they can't get PASRR specialized services coordinated with a behavioral health or developmental disability provider? Let us know. We are looking for data. We know that there are a lack of services, and we know that certain areas of the state also really struggle with being able to coordinate services based on lack of provider availability. We know that, but we don't necessarily always have data to support that. So if your facility would let us know, hey, we're having a difficult time coordinating talk therapy for this individual, let me know, because then I can go to that RAE in your area, talk to one of their care coordinators and say, hey, what are your resources for talk therapy in this geographic area? We have a nursing facility. Colorado is required to provide these specialized services. Let me help you guys. So kind of that warm handoff of, here is your person at the RAE that you guys can contact and make sure that you get the resources for this individual. Let's see, PASRR identified services required versus recommended. Margaret will touch on this a little bit as well, but if an individual has a yes determination on that notice of determination, then those specialized services that have been identified are required. Everybody who has a potential PASRR condition gets a level 2. Sometimes those level 2s result in a no determination. If the no determination is the result of the level 2, those PASRR specialized services that are identified are recommended. They're not required anymore, but they're a really good shortcut to care planning to meet that individual's mental health needs. Let's see. All right, Margaret, I'm going to pass it over to you to go ahead and go through the tags.
Perfect. Thanks, Chellie. So there are 3 citations that are directly related to PASRR. So I've put in the slide deck so you guys have reference for them, the federal language around each citation, and then the intent. So I'll just quickly go over them with you guys, but they're there in the slide deck so you guys have them for reference. So the first one is going to be that F644, which is the coordination of the PASRR in the assessment. So the short one, this is where you guys as the nursing facility are providing, documenting all of those specialized services. And again, like Chellie said, the key is that documentation. We hear oftentimes that folks are refusing, but you have to have that documented. So when survey does come in, you can clearly show that they've been offered and they're refusing those specialized services. So that is 644. It's pretty simple. So next slide contains the intent for you guys around 644. And then we'll go to the next slide, which is 645. So that is the PASRR 101 regulation that you guys, nursing facilities, must complete the PASRR process prior to admission. So since we are no longer in the PHE, now almost 2 years out, we have to have the PASRR process completed prior to admission. So that includes, as Chellie talked about, that level 2 evaluation, and then the issuance of the NOD, which is going to be in your facility name and signed either by myself or Chellie. That needs to be completed if it's required, if a level 2 is required, prior to that person being admitted to your facility. So that is the gist of 645. So do not admit anyone until that PASRR process has been completed. So, and then the very last regulation around PASRR, so Chellie, if you could go to the next slide, is going to be 646, and that's notifying the state, so Chellie and or myself, of a significant change. So as Chellie talked about, if there is a change with their PASRR condition or a change of meds, it's kind of a gray area. So we do have a crosswalk that we offer to social services directors. We always encourage them to reach out to us if they have questions. But the regulation around this is you have to notify us of that significant change. It currently follows closer to the MDS schedule, but as Chellie talked about with that NPRM, it's going to be 72 hours. So that is our current guidance to nursing facilities, if they can just get in the habit of notifying us within 72 hours. When the NPRM goes into effect, they will already be doing it, so we're on top of it. So that's 646. So these regulations for your folks that do have PASRR conditions. So as Chellie said, the outcome, Chellie, if you could go back one slide too. So if the outcome of your level 2 is a yes to PASRR condition, it's pretty straightforward. We're telling you the specialized services that you have to provide to that resident and then document if they're refusing or not. So those folks are the straightforward folks. The ones that we get a lot of questions about are those people that have had the level 2 evaluation completed, but the outcome was no PASRR condition, but there are still those specialized services listed on the NOD. So as Chellie said, those are now just recommendations, but as we tell the nursing home folks, it's a great place to start because you have 3 independently licensed clinical folks that have reviewed those and agree with those recommendations. So it's a great place to start those behavior health care planning, seeing how you can incorporate those into your IDT. Oftentimes, I know Chellie, I'm just throwing these out here, she could probably add some, but like we see medication review. So is that someone that you can add to your psych farm and do a medication review for them? So kind of looking at those of how can you take those now just recommended services and incorporate those into those behavior health needs for that resident. That's where we always get a lot of questions, is that required versus recommended? So for your PASRR folks, it's easy. If it's a yes PASRR condition, they're required. We're telling you what to do. Now you guys just have to do them. It's really those folks that are now just recommended. So as long as you guys have done that PASRR timely, you are in PASRR compliance with those folks. So, and then I think on the next slide, we have some quick tips and links for you guys, our PASRR website, our calendar of events, our tip sheets that we have with our current vendor, Telligen. So a lot of resources there. And then our contact information, I did put that in the chat, but then the Telligen help desk. And then if you guys ever have questions for myself or Chellie, always reach out to us. Our emails are on there. They're also on the PASRR webpage. If you ever don't remember it, just you can pull up the PASRR webpage. We're at the bottom of that. So we are now open for questions. I don't know if there are any in the chat.
There are a few. Some of them came privately. One question was, you mentioned that we could document maybe a disagreement or a different plan from the PASSR. Does that apply whether it's required or recommended?
Yes, both. So you can document in your PASSR progress notes or in your physician progress notes that you reviewed the PASSR, you agree with it, or you have concerns about either the diagnosis or a clinical intervention that is either recommended or required. As long as you're providing that documentation for survey to see when they come in, then Margaret, they would be found in compliance, correct? Okay.
Thank you for clarifying that. Yeah. And you mentioned that there's a resource for obtaining, sorry, for a resource for counseling. Who did you say you would reach out to, or
Yeah, so I
reach
will
out
see
to
if I can
as well?
find the document and share it with you, Dr. Pallet, and then you can distribute it to your group. But HCPF had published a I believe it was a two-page document for nursing facilities on how to contact their local RAE, their regional accountable entity, and that's the Medicaid Managed Care Organization. And that is how you can get services coordinated. If you do not have a like a private practice group that comes into your facility, like behavioral health services or Deer Oaks or senior counseling group, that sort of thing.
That'd be really helpful.
Yeah, I'll put that on my follow-up to do.
Appreciate that. And then you've shared with us the Telligen resources. I know that Mariah's here. She'll tell us a little bit more about Telligen, but it sounds like there's some arrangement with Telligen and facilitating some of these questions for PASSR. Is that right?
Yes, Telligen is our current state vendor. So they are the ones who are, when you submit your PASSR, your level 1 screen, Telligen is the one who receives that through their e-portal. They provide that clinical review, and that is the online software that you would go into and download your PASSR information for your medical records at your facility.
I know.
Couple more questions in the chat box. And thank you, Jenny, for that resource. What about the ICD-10 codes? Sometimes the nursing home has a different code than what the PASSR has been using, and they're incongruent.
The ICD-10 codes, I believe, are also in DSM-5-TR. So you're talking about the F codes for behavioral health?
I think that the diagnostic codes sometimes don't match exactly.
Okay. Well, PASSR goes through DSM-5-TR. So if you guys are, at the nursing facility, you're using ICD-10 codes, you would report those. And if Telligen needs to consult with myself or Margaret, we can do that on the back end to see what it would be closest to and go from there.
Thank you. Dr. Shepard, you have your hand raised, and there's a question from Dr. Gahm in the chat also.
Yeah, so just so I understand, so each state has their own definition of what a PASSR condition is. Is that correct?
There is a federal definition, and then each state in their rules has their own definition as well, yes.
So you may or may not know the answer to this, but so the definition of whatever your PASSR condition is kind of feeds into what your quality metrics are for psychotropic use. So when we compare ourselves against the national average, we're not comparing apples to apples, are we?
Doesn't sound like it, no.
Thank you.
And you mentioned that there is a 30-day time limit to challenge the level 2 diagnosis. A lot of our psych farm meetings happen within a month, but sometimes 3 months later, which might be outside of that 30-day window. How should we deal with this?
That 30-day window is actually for the resident and or their family or guardian to appeal the notification determination. That 30-day timeframe does not pertain to the provider at the facility. That's for the family and or the individual to appeal that level 2 decision. I hope that's clarifying.
Gotcha. So even outside of that window, we could potentially still.
Yes, you guys as providers could still document. It's just that 30-day window for the appeal of the determination.
Thank you. You mentioned that OBRA should be notified for diagnosis or medication changes. Does this include changes in the dose of the medication or a change of an agent within the same class of meds?
So this is really sticky, and I'm glad you brought it up. We've done a lot of clarification around this, and we're still working on getting better rules around this and getting better guidance around this. So for those of you who have been around historically, back when, if there was a double up of antidepressants, you had to report it. If there was a dose change, you had to report it. Since Telligen has been our vendor, so since March of 2021, that guidance has changed. And to be very honest, it may change again. However, currently, we do have a crosswalk Margaret mentioned of when to report status change. And so just because you change a dose of Effexor does not mean necessarily that that has to be reported as a status change. What we're looking at is clinically, if they're having more significant symptoms, they're having different clinical symptoms that have not been historically addressed, then that may be where a status change comes in. If you're treating someone who has a major depressive disorder and recently they've started having some psychotic symptoms in addition to that, and you're looking to add Abilify, then that would be a status change because their symptoms have become more significant and have changed in a way that we would want to potentially do a new level 2.
Appreciate that. Okay, and thank you for the links in the chat.
Thanks, Margaret.
Yeah. Why don't we take our final question from Dr. Eber? This will be a great segue to Mariah. But since Telligen doesn't have a current active contract except for infection control and COVID, are they still providing this service for PASRR? So I'll let either one of you take that and we'll segue into Mariah's updates.
They do have an active contract with HCPF, so they are our PASRR vendor for Colorado. So they do have an active contract with us. Sure.
Thanks, Margaret. That was a perfect segue. So hi, everyone. Happy New Year. I wanted to give a quick update on the Telligen Quinn QIO contract. So Telligen is still providing support for PASRR. That is a separate contract than the Quinn QIO. So right now, we had received a 12 scope of work contract extension from CMS to be able to continue some of our support. However, the support that we're offering is specifically in the areas related to COVID-19 response and COVID-19 vaccinations, and this will go through March 7th. During this time frame, we're still receiving referrals or notification of nursing homes that are experiencing COVID-19 outbreaks. So then we provide technical support, and then also nursing homes that maybe with low up-to-date COVID-19 vaccine uptake. We do still have our resources page, our learning management systems, that are available for use, and along our quality improvement facilitators remain available to share resources as needed, but our one-to-one technical support to be able to hop on a call does need to be limited to the CMS guidance during this extension period. And then we do still have our nursing home quality essentials with a focus on infection prevention control series that we do twice weekly on Tuesdays and Thursdays. One last thing I did just want to share with everyone. Though our funding for our contracted partnership with CPSN pharmacies had ended back in August, we've been working to develop a strategy to continue support for nursing homes that need or are looking for on-site vaccine clinics and vaccine services. So we've identified 159 pharmacies in Colorado, comprised of CPESN pharmacies, King Supers, and City Market pharmacies that are willing to offer vaccine clinics to nursing homes. So some of the pharmacies might have a mileage limit or a minimum dose requirement in order to send out a team, but generally they do this at no charge for any extra services or fees and come on site to do a clinic. And for the nursing homes in the Denver area, we're also promoting a program with the Front Range Area Health Education Center and CDPHE that will send a team to help with vaccination for both residents and staff. But so with that, that's all I have for an update today. If you have any questions, please feel free and put it into chat or let me know. And that's all I have. So thanks.
Perfect. Thank you, Mariah. I think we can move to Chad here with CDPHE for updates. Chad?
Hi, yes. Good afternoon. Just a few things on our end. I want to let you know we did have our nursing home roundtable earlier this morning, and there we discussed strategies to improve state and community collaboration during the survey process. We want to build on seeing each other in a more positive light and improving communication and consistency during the survey process. We reviewed frequent citations from federal fiscal year 2024. There were a few changes. We're pretty much consistent with what the findings have been across the nation. But I did want to point out that we are seeing an increase in the severity of significant medication errors and the process for reconciling medications and taking and following physician orders. That's come up in a number of situations. Immediate jeopardy situations from October 1st. We've had a number of elopement issues, sexual abuse. There was an entrapment issue. And I did want to point out to the group that CMS did a comparative survey and called 2 immediate jeopardies during their inspection. I want to remind the group that February 24th, there are revisions and clarifications to the interpretive guidance, including admission, transfer, discharge, changes to chemical restraints, unnecessary psychotropic medications, the resident assessment, administration, COAPI, and infection prevention and control. These changes may affect other regulatory areas, including professional standards, the medical director, pharmacy, etc. And these changes have resulted in changes to the survey process software. So if there are any questions, I'll be happy to answer them. If not, that's all I have today.
Okay. I don't see any questions. Thanks, Chad. And last but not least, we have Jenny Albertson with CHCA.
Hi there. Is it all right if I share my screen?
Please.
Okay. I have just a few updates that are pertinent to you all. I like to send these out to you so you have all the links as well. So I've already sent these on to Sing so she can distribute at her discretion. Let's see, slideshow. There we go. Okay, there's my contact information. Should anybody wish to have it, I am completely on call. Do not hesitate. You all have my ear anytime you need it. First off, just wanted to give you a heads up that the vaccination reporting requirements are adjusting. They've put out a couple of memos from CMS and the NHSN system even hosted an additional webinar today. So the main thing that is changing, I think I put this on the next slide. Yeah, they will be removing the pieces about healthcare personnel's eligibility to work. And they've removed their vaccination status as well. And they've just simplified it to resident vaccination, cases that are confirmed, and hospitalizations. But do note that you're seeing your favorite respiratory illnesses there lumped together. So it's now COVID, flu, and RSV reported through the same mechanism in NHSN. And this was effective January 1st. So your IP nurses should be doing this already. But you might just ask the question in your COAPI meeting because you are directing the medical care, obviously. Congress averted a shutdown and did pass a spending package. Of course, it's never what everyone wants. And of course, we did not win when it came to the physician fee cut. So as of January 1st, average payment rates under the physician fee service are being reduced by 2.83%, including Part B therapy and other services to skilled nursing patients. ACA is trying to continue to prevent the cuts from actually being implemented. But it looks like it's a done deal since they passed the actual spending package and this was in it. The staffing mandate also was not addressed through this end of year budget package. It's still going forward as planned. We are hoping that whether it's the litigation that we've put forward in various states or just new direction from a regulatory standpoint for CMS's enforcement direction, that we may see some changes on that and modifications. My number one hope is that we actually see some sort of a workable waiver process instead of an after the fact, after you're cited exemption process. At the very minimum, that's my hope. So we'll see. The status of telehealth permissions, I did post this in my blog. So if you're a subscriber to that, you already have all these links. This is not new, but physician visit telehealth did end with the PHE end. CMS had waived the requirement that physician visits had to be made by a physician personally, and that is now back in effect. So please do not be doing telehealth and trying to bill for it, because you will not be paid. And on that note, there are things that were provided for ongoing and in some cases made permanent. And one is opioid use disorder treatments. That's built in with an add-on code. It allows for audio video two-way communication for the prescription of those items, as well as behavioral health treatment ongoing can be done through telehealth. And that is being finalized in HCPCS codes for people to be able to bill. That includes all of our mental health providers that we customarily use. So if you're in a rural area and you can't get face-to-face for your folks, it is possible for them to bill for these behavioral health treatments still and ongoing. That should not be disappearing on us. And then these are the therapy codes that we used to be able to bill for that are no longer permissible to be billed for under telehealth. So if you're ordering these and you don't have therapists in-house to provide these services, they're not going to be able to bill for it at the SNF. So please note those. And if you want complete lists, I've given you the links to the 2025 CMS telehealth services list, as well as the summary of the changes for the physician fee schedule for 2025. And then please note that Colorado also has a separate guideline for Medicaid telehealth billing for things that are not covered under the Medicare service billing. This is going to change how we do wound care orders in the future. February 12th, they are shrinking the number of wound care products that will be covered under Medicare from 70 to 18. And they are also limiting the coverage of wound care products for diabetic foot ulcers and vascular foot ulcers down to a limited number of visits. And they have to be justified if they go beyond that 4 treatment threshold. It used to be 12. It currently is 12. So if you want to read more about that, I've put the links in there. The McKnight's article is pretty extensive, but of course you can look at CMS memos if you want the actual nuts and bolts. And then heads up that we have some opportunities for education for the folks on your interdisciplinary teams. Our infection prevention control nurse boot camp will be co-taught with our friends from Telligen on the 15th. And then on the 8th, for half the day, we're going to have an activities survey readiness class. So if you have a new activities director or someone you just feel like needs the once over, give them the heads up that they can attend these virtually. We are offering everything hybrid these days, and I'm offering an in-person option for the activities one, but if somebody wants to do it, it's going to be me and them, because so far everybody's virtual. So, but we always will offer the in-person and the virtual moving forward. All right. Thank you so much.
Thanks, Jenny. We have to go off schedule for 1 second. Dr. Greg Gahm has asked for a few quick minutes for an influenza update.
Hey, this will be really fast. We are sort of ahead of schedule. Influenza is just crushing emergency rooms right now. We are full of influenza, which means that there's a really good chance in the next week or two, you're going to start seeing it in your facilities. There's an article that came out recently that compared starting Tamiflu day 0, which is like as soon as you suspect it, day 1 and day 2. And it was really clear there were significant differences in morbidity and mortality at 30 days the sooner you started it. So my recommendation, you get somebody in your facility with a new onset high fever and non-productive cough, start the Tamiflu, send the test. If the test comes back negative, you can always stop the Tamiflu. But if it comes back positive, you did the right thing. So that's the first thing. The second thing is just 1 minute on H5N1, the avian flu that you may have heard about. Just a couple quick notes on that. So far, it's not transmissible person to person, but there have been 2 really worrisome cases recently where they looked at the genetic code and found that in one of them, the H5N1 had gained a significantly better ability to attach to hemagglutinin, which makes it a much more deadly option. And in the second one, there was some movement toward genetically being able to have it transmissible from person to person. The biggest thing going on for us right now is getting people vaccinated. The way that this is going to become the next pandemic is somebody's going to have seasonal influenza and then also get H5N1, and there'll be a reassortment of genes within a single patient that will then give that H5N1 the opportunity to be transmissible. And then we'll have another pandemic. What will separate this from COVID is that right now the case fatality rate, if you get a human that gets H5N1, is 50%. Half of the people that get it die. And, luckily it doesn't make a lot of headlines because there were only 67 cases in 2024. But if it gets that ability to move person to person, yeah, it could be astronomical. Anyway, that's it, Chris. Thank you.
Hey, Greg, this is Dave Shepard. Is there a specific vaccine available for H1 or H5N1?
They have some available. There are two different things going on in the vaccine world. One is a universal vaccine against M5, which would cover all influenza vaccines, all subtypes. The other is with mRNA. It is possible now with the H5N1, there are already 3 different groups, Moderna, Pfizer, and somebody else, that are developing that vaccine and should have it available should this come about. But some of that may depend on what happens in this next presidency where vaccines are taboo. So yes and no.
Great.
Thank you so
Thanks,
much.
Greg.
Sure.
We always appreciate that, especially right now during this season. And now I will introduce our last speaker, Dr. David Shepard, and he is going to talk to us about restless leg syndrome and periodic limb movement disorder based on the clinical practice guideline from the American Academy of Sleep Medicine.
Yeah, thank you. Can you hear me okay?
Yes.
Okay. Yeah, I'm primarily going to focus on restless leg syndrome here. Let me see if I can get this going. All right. Does that look all right, you guys?
We can see it.
Okay. Well, that's all I need. So there was an update by the American Academy of Sleep Medicine. I believe it was published in the January 1st, the Journal of Clinical Sleep Medicine, I believe. And it updates the treatment of restless leg syndrome and periodic limb movement disorder. I'm going to focus primarily on the restless leg syndrome. And just by way of background, there's obviously primary and secondary restless leg syndrome. Idiopathic or primary RLS has a pretty good familial link of 40 to 60%, so it might be worth asking patients about their family history of this. There's several genetic loci that have been identified, and most of them involve some type of dopamine signaling or iron metabolism, which kind of makes sense based on the therapies that we've used in the past to treat it. Secondary RLS, obviously, we think is related to some other identifiable cause. CKD has a pretty high association with restless leg syndrome, sleep apnea, some other medications, antihistaminergic medications, maybe some of the anticholinergic stuff we would find on Beer's list, serotonergic medications, obviously antidopaminergic medications, caffeine, alcohol, all have associations. I kind of wanted to just highlight there's periodic limb movement disorder of sleep, which is talked about in this guideline as well. And just by way of a reminder, periodic limb movements in sleep occurs exclusively during sleep. It's involuntary, patients are unaware of it, and the only way to diagnose it is with a sleep study. Whereas restless leg syndrome occurs during wakefulness. There's an urge to move your legs. Some people describe it as a pins and needles sensation. Some people describe it as a pain. And these, so they're a little bit different. They do sometimes walk together, but not always. You can see people with periodic limb movements of sleep who also have restless leg syndrome and vice versa, but they don't always have to be seen together. And this is just for reference, another kind of chart about primary and secondary RLS. So again, these recommendations from the American Academy of Sleep Medicine, and the target group that we're concerned about here is adults with restless leg syndrome. They also talk about children as well, but I'm not going to focus on that. The recommendations are classified as strong or conditional with varying levels of evidence. And this is the meat of the talk right here. So this is the one slide that kind of says it all. I'll go into some details with other slides, but this is the basics here. They are just to evaluate for and treat underlying conditions that can exacerbate RLS. And they really highlight iron deficiency and iron status as one of those exacerbating conditions. They also talk about sleep apnea, CKD, end-stage renal disease, again, alcohol, caffeine, and medications. If you look for correlations between other chronic diseases and RLS, there are a number of chronic diseases that have a correlation. Whether or not that's causative, I don't know, but it would probably be wise to optimize our therapy for chronic diseases, as we treat RLS, as we should be doing anyway. Really, the meat of this recommendation, in my opinion, is now there's a strong recommendation for the use of alpha-2 delta ligands as first-line therapies. That would be gabapentin and acarbol, gabapentin and pregabalin. And I'll talk a little bit more about the difference between these a little bit later. They're moving away from using dopaminergic drugs like pramipexole, ropinirole, and rotigotine as first-line agents, primarily due to augmentation. And there is a new non-pharmacologic treatment, high-frequency peroneal nerve stimulation, which I'll show you a picture of one of the devices and talk about that a little bit as well. They start the update with just a general good practice statement for management. And, as we discussed, you want to kind of optimize your chronic disease therapy. You want to address exacerbating factors like alcohol, caffeine, other medications, sleep apnea, CKD. Obviously, pregnancy can exacerbate it, not a disease state, but it's something to keep in mind. We don't see a lot of that, so don't have to worry about that much. It talks about iron studies and regular testing for serum iron and emphasizes that you want to conduct your iron testing in absence of supplements and foods with high iron content to really try to get a good picture of what your iron status is. The update also provides iron supplementation thresholds. It seems to use ferritin quite a bit for that. Serum ferritin in adults less than 75 or transferrin saturation less than 20. You probably want to consider oral or IV iron supplementation. And then there's a recommendation for IV iron ferritin for level 75 to 100. I think there's some studies with iron carboxymaltose that use those levels. So I think that's why they specifically picked those levels for the IV iron. And the strong recommendations, again, are for gabapentin and acarbol, gabapentin and pregabalin as, in my interpretation, as first-line therapies. They also recommended IV ferric carboxymaltose, which there was at least one study that showed it improved symptoms in patients with decent clinical significance. The difference between gabapentin and acarbol and gabapentin is gabapentin and acarbol is basically a prodrug, and it has better absorption than gabapentin does. It is also the only one of the three that's FDA approved for severe restless leg syndrome. It's only available as a brand name drug. I think it's Horizont. I could be wrong, but it's only available as a brand name drug. So it is the most expensive one as well, $300 to $500 per month. But mainly it's the absorption and the fact that it's available as an extended release drug with FDA approval for RLS. I think that's why it got the first tip of the hat for use in treatment. Some conditional recommendations are given for, excuse me, ferrous sulfate, so oral iron, which is probably the one that we all use the most, simply because it's easiest. There are other IV iron formulations available. They particularly talk about IV ferrous carboxymaltose, and I believe that's given as a 1 gram IV infusion. So in the nursing home, that may be a problem for us, right? A lot of my nursing homes won't do IV infusions like that. But if you have access to an infusion center, or if your nursing home would do it, then it may be an option for you. Some other conditional recommendations are dipyridamole, extended release opioids, which we obviously need to be careful with, and high frequency peroneal nerve stimulation. And this is kind of the new kid on the block. And I provided some links here for other resources that you can look at this further. There is a company that has created a device, and I believe it's the only FDA approved device for restless leg syndrome at this time. It's called the Nidra, and here's a picture of it. It's basically a couple of bands that you put around your upper leg that provides nerve stimulation to the peroneal nerve. It's supposed to act pretty quickly. They have studied it. The data is available in clinicaltrials.gov. The name of the study is the Restless study. Very clever name. They extended the study as well. I don't have that data available. At least superficially, it looks like there's some efficacy here. You have to take into consideration that this study was funded by the company that markets and builds the device. I would love to see a study from some other third party, but hopefully this will be a non-pharmacologic intervention that we might be able to use. In my opinion, the pharmacologic interventions aren't very effective, so I would love to see another option. Other treatments to consider, or treatments to use with caution, rather. The dopamine agonists have basically been given a backseat, and it's not recommended for standard use any longer. Those would be levodopa, pramipexole, rotigotine, and ropinirole. You may consider it for short-term use. Generally, longer-term use is where you start to see augmentation with these therapies. And augmentation, in short, is when the medication's effective initially, but over time it causes the worsening of the symptoms, which might lead to increases in the dosage, which could lead to things like anxiety, panic attacks, psychosis, some of the psychiatric adverse effects from the drugs. Just incidentally, pramipexole and ropinirole target the dopamine 3 receptor. And so they think that may be why you see these impulse control disorders and anxiety with these medications so frequently. Whereas levodopa is not specific. It's not going to target a specific receptor. You're still going to see side effects from it, though. I've included a link here to recommendations. It's really just some information on augmentation and potential ways to deal with it, which I found interesting. There's also an increased risk of psychiatric side effects. And here's another article that kind of talks about that a little bit. I believe the odds ratio was 1.7 for, I don't remember the drug specifically, if it was, I think it may have been all three of the drugs together. But there's a 1.7 times possibility of new onset psychiatric adverse events in patients taking these medications. And interestingly, in this study, they did not look at patients with existing psychiatric disorders, I don't believe. Treatments no longer recommended: bupropion, clonazepam's on there. So benzodiazepines, we try to stay away from those anyway, but occasionally in certain situations, it may be your last resort. Valproic acid no longer recommended either. And I've included some other slides with some further information if you guys want it, but really this is the slide with majority of the information you need. And that's it from me.
Thank you for doing that overview for us and looking at the guidelines. There are some questions in the chat box. One of the first ones was, are the restless leg syndromes associated with all antihistamine medications or just those with anticholinergic side effects or effects?
I don't know the answer to that, to be honest with you.
Yeah, very interesting question.
Yeah.
Thank you. What about when using gabapentin or pregabalin, Neurontin, Lyrica, would the use be just HS only or more of a BID, TID dosing?
I believe gabapentin is recommended HS, and I didn't actually, the one to look up would be gabapentin and a carbonyl, which we might not be able to afford, but I believe that is QHS dosing as well. But you'll
Yeah, and Dave, just because it's ER version, it's just once daily anyway.
Okay. Yeah.
Horizon looks like the brand name for that.
Yeah.
And Dr. Eber has a comment here about vitamin K therapy. What do you know about that?
I know nothing about vitamin K therapy for it.
In the
Yeah,
chat.
I didn't see it mentioned in there, but I may have missed it.
Good to know. No, thank you. Other questions from the audience? Cool. Well, thank you very much. We will share these slides if you don't mind, plus the slides from our other presenters. And we thank you all for joining today for our combined monthly meeting and journal club. What great discussions we had. Please go ahead and share us any questions that you have, send them by email. We look forward to seeing you at our future meetings. Have a great day.